And we keep it to these 14 because we can help manage quality that way. They're scalable across the country. We can source them and we can manage quality. So I think, it's about, again, it goes back to asking the right questions of the vendor that you're working with, your linen provider, to find out what they're doing on their end to kind of manage those systems and seeing how you can then bring it to bear and develop KPIs jointly. And by the way, that's the way to do this, is to jointly come up with KPIs.
Without supplies, there's no surgery. Without products, there's no patient care. Welcome to Power Supply, the healthcare supply chain podcast focused on helping you navigate the intricacies of logistics, purchasing, contracting, and supplier relationships. Each episode, we speak with healthcare executives, supply chain leaders, and innovative entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the loading dock to strategic sourcing, from buyers to the C-suite and across the enterprise, we tackle the real-life issues impacting the healthcare supply chain. Whether you're tuning in for conversation or inspiration, we're glad you're here. You're just in time to hear it from the source and stock up on insight. So sit back and plug into Power Supply.
On this episode of Power Supply, we are going to be speaking with actually an old friend of mine, Jason Isherwood. We'll tell you all about how Jason and I know each other. He's the VP of Enterprise Sales at ShiftMed, and we're going to be talking about linen services. And this is an area, Gary, that you yourself identified as an opportunity that still is out there. It may not be low-hanging fruit, but there is opportunity for savings, consolidation, and establishing quality across an entire healthcare organization.
Yeah, Justin, looking forward to hearing what he's got to say. Been in this area for a lot of years. There's significant dollars in there on the purchase services side. Lots of agreements, lots of different bits and pieces that I think he's going to talk to. When you say laundry and linen, it's a bigger scope than just saying laundry and linen. So how do you pick it up? How do you keep it clean? How do you get it back? And what are those pieces to that contractually to support it? So looking forward to seeing what he has to say and him just providing all the information we need to share with our listeners.
All right, up next, Jason Isherwood.
I'm Hayes Walder.
This is Gary Skinner.
And I'm Justin Poulin.
From the studios of Healthcare HQ, you're listening to Power Supply.
Jason Isherwood, VP of Enterprise Sales at ShiftMed, joining us today to air his dirty laundry. And by the way, Jason, you're the one that threw that out there. So I'm running with it. And for the listeners, maybe a little background. I'll even talk about how you and I know each other. But many, many years ago, I left nursing, my work as a provider, to become a medical device rep. And one of the things that I knew right off the bat was that I had absolutely no idea about the business of healthcare, and that was going to be very important in my new role, especially in kind of a new arena for me. And so one of the things that I did to expand my knowledge base was I began to participate in my local ARM chapter called CPAC, which is the Southeastern Pennsylvania area chapter of ARM. And Jason was on the board with me. I was the education chair for 5 years.
Absolutely.
And Jason, you've served in various capacities, and I know you're still serving in capacities as we speak today. So you and I have quite a history going back over a decade.
That's right. They have a way of holding on to you, dude. They don't let you go. So you're in it for life most times. So it's been great. But no, we served. That was many years ago. So I'm still going strong as the treasurer.
Jason, why don't you give everybody a background on yourself and specifically, your experience in linen, because that's going to be the topic for today. So, what makes you a subject matter expert in this area, or as a SHME, as Gary would call it?
A SHME. We got to have the SHMEs on board. Game on. Let's go.
Okay. A SHME. That's a great way how you guys all put that. So thanks for the question, Justin. Up until about a year ago, I spent roughly 20 years with one of the leading providers of healthcare linen and laundry services, working in a variety of roles, starting in our service function and ending my time in our senior leadership team, leading our key account management or enterprise sales customer success function. And in that role, I literally had to build a model on how we approach our business as the landscape in healthcare was changing. During that time, I had the pleasure of working with most of the major health systems and GPOs across the country as we embarked on that journey of change. The 2 decades that I spent really gave me a lot of experience and expertise on how linen and laundry providers operate, how they do business, what's really possible when you're approaching that vendor on kind of the things that you're looking for and driving change in your system. Also now coming from a different perspective, my experience as a consultant for on the provider side, serving as CEO and founder of Insights Health, where really we're trying to bring some transparency to this whole category. And interesting enough, I really see the need for a SHME, as you all are putting it in this category, as over the last 20 years, we've literally seen the healthcare completely change. It was more of a private practice and brick and mortar hospital type delivery system when I started. Now with merger and acquisitions over the last 15 years, we've seen it transform to health systems or, IDN based delivery system. So not only has the way the providers deliver care changed, so has how they made decisions as well. As those decisions and delivery systems have evolved, so has the approach to the vendor management, I believe. And this has really pushed vendors to move from more of a transactional mindset to a consultative one, looking at the system as a whole rather as practice by practice or department by department.
Well, you said it went through a lot of changes, but healthcare was going through a lot of changes. So to your point, adapting to that model, where do we land today? Because like you said, with mergers and acquisitions, and even as Accountable Care has had healthcare organizations begin to expand their footprint more and more into non-acute settings, obviously, I would imagine the delivery model is very different for linen services, depending on, which area you're talking about. And so, when it came down to contracting, who owned it? Were there lots of different owners? And what is the current state today?
It's interesting, to kind of level set it. Start at the beginning and I'll end really quickly. But at the beginning, it was like you spent time. It was either the doctor, right? Private practice and or in a hospital. You know how much time I spent in basements next to morgues, believe it or not? Because that's where materials was, right? The materials manager was down in that's where their office was down in the basement. So it started there. And then it's kind of blown up to this thing where usually I'm in a separate building with supply chain professionals really that are managing the category from kind of afar, I believe, which is very challenging for them in particular. And another piece of this, for us to kind of better understand what this category really is, because I think there's a lot of misnomers there. And I'll give you some, I think data kind of helps us tell a story. It does. And I think it's important because maybe not everybody realizes this. And some of this things I'm going to talk about kind of came from the Medicare cost report. And Definitive, by the way, has done a great job of kind of capturing all this, Definitive Healthcare. So on average, and there's no wow, it's interesting because there's not going to be a wow moment right away, but on average, hospitals spend about $500,000 a year on laundry and linen expenses. It's not like you look at it, you're like, wow, that's $500,000 a year. But now take that for a second. I'm talking hospitals because hospitals and health systems we're not using those words interchangeably anymore. Take an SSM Health in St. Louis, right? It's 23 hospitals. That's what? $11.5 million, right? When you take it and you start building that out and you look at the average reduction opportunity that's there, around 8 to 10%, it's like 1.1 million. Let's go wide view here. 4,700 hospitals across the country, $2.4 billion in 21 on spend on healthcare laundry. Taking same formulas, there's probably $300 million worth of low fruit kind of savings hanging out there for these guys. And so some of these numbers, when you think about linen, you might not necessarily feel like, what is that? It's pretty big. There's a lot out there and there's a lot of opportunity, for sure.
Jason, I'm going to back you up just a second because I know what you mean when you say laundry and linen. We're assuming a lot of different things. Go on the breadth. I mean, curtains, scrubs. I know you know, but share it with our listeners so we know we're talking about laundry and linen. Please, just kind of give some ideas.
Yeah, and every company kind of defines like the product lines differently. But I'll just say the way I look at it is, when you think about it, sheets, pillowcases, patient apparel, which is the gowns, scrubs, lab coats, curtains. Bed pads, reusable bed pads. We'll talk about COVID times for a second. FR products, right? Reusable FR products, which by the way, we're like, it just keeps coming. So there's mats is another one that's on there. It's kind of handled through the environmental services, but they are definitely anti-fatigue mats. We're kind of pushing that. Microfiber mops were in that bucket too. So when you think laundry, linen, that's the breadth of products that are kind of being provided by linen providers in that space. And
Jason, thanks for clarifying that, because I like to take it to a fourth grader level at my level, fourth grader. I always like that, so I can understand it. Hayes, who's not with us today, I'm not sure if he's at the fourth grade. It might be kindergarten, preschool.
Oh, no.
Airing his
you
own
were gone for so long, Gary. Yes. And you got picked on so much, and now Hayes misses one show, and you are all over it.
It's on. It's only because I love him, man. It's only because I love him. But yeah, so I think you kind of keyed on it, Jason. Part of this, identifying the areas, like who are your key stakeholders you're talking to? I mean, it's supply chain, but it could be a myriad of people from the acute to non-acute setting, to Justin's point. Please labor on that a little bit.
Yeah, and the way I used to look at it is I used to call them buying groups, right? Like, how do health systems buy? That was kind of from the vendor perspective, how I was kind of looking at it, and I bucket it really, because there's a lot of different titles. Titles are a lot of things. What's Coach Prime say? Coach Prime says the title just tells me where to find you. That's about it. So I love that guy. So when I look at the buckets, it's finance, right? And we obviously know because finance is taking so much control, especially over supply chain. Finance, supply chain, infection control prevention, huge play. These are all the people sitting at the table when we're having these. There should be sitting at the table. That's the thing. Should be sitting at the table when we're having the discussions. Clinical operations. Now that's pretty big. I know when I say clinical ops, it can be a lot of things, but I mean, it is very big. I mean, it's everywhere from administrative directors to practice managers, post-op, peri-op. I mean, there's so much involved in clinical ops, and having representatives within that process is important. And then there still is materials. So when you look at a health system and the brick and mortar hospitals that are still there, they still have materials folks, directors on hand in those facilities managing the linen. From the perspective of hands-on managing the linen, maybe not contractually. So contractually, it's being kind of managed from afar with supply chain. But those are the stakeholders or the buying groups that are really the ones that have the most impact on the decision-making process and really have the most impact on who you're using and what those KPIs eventually look like when you're kind of like trying to develop those.
Like current state, you mentioned contracts. Is this like one big master service agreement and because now that we've aggregated it, like how many different contracts would there be? What's that?
What you want it to be, what it is, what it could be. I'll tell you, the ones that haven't tackled it at all, they will have, I will bet you they have 15 to 20 to 30 different vendors, because you got, Susie's Dry Cleaning's doing stuff. There's so much stuff going on out there. The ones that have tackled this issue, that have tried to tackle the issue, maybe narrowed it down to 4 or 5 potentially. So many hands in the pot, diminishing returns eventually for them. They can't really grasp it. Other, competing priorities. In reality, if you could really get it down to 2, right? An inpatient, acute, and then a non-acute outpatient provider. There's really only probably 1 to 2, one across the country that I'm aware of that really is kind of doing both. And frankly, the inpatient side, they just kind of started doing in the last probably 17, 18 months. And it's because in reality, it's 2 different models. It really is 2 different models. It's 2 different ways of looking at things. And anytime they try to combine it into one, or as somebody told me once, one throat to choke, that's what we want. We want one throat to choke, Jason. That's what we'd like to have. It doesn't tend to work out in the end. When you start measuring or you start managing the, ARM here, cost quality outcomes, right? I'm going back. I'm going to plug ARM a little bit in this thing. Hopefully nobody minds, but it's in reality.
Hey, by the way, we don't mind. This episode is approved for CEs for your CMRP.
We love it.
We don't mind at all. But Jason, so you're saying whittle it down, but you're talking about acute versus non-acute. Is the issue or the differentiation there? And I really need to hear this from a supplier perspective, why they don't tackle both. I understand it's 2 different modalities, but what would make it so different that one company would only tackle one versus another? Because I think the obvious logistic difference is just transportation, right? You could do one big load pickup in the acute setting where you've got a lot more points of contact and you're driving around a whole lot more in the non-acute setting to get to the same volume, which is sort of inherent. That thematically, plays out across all kinds of different contracts, right? So what is the reason
Absolutely.
that suppliers in this space couldn't just easily do both?
You hit distribution model, right? That's the first thing. Distribution model, semi-trucks, cart exchange compared to like step van type, step vans where the inventory and the service levels are different and are expected to be different. The other piece of this is quality of product.
But they're all going back to the same place to get laundered though, right?
But it is the main difference is the align of how the plant is built. So what's actually in the plant? So is it geared toward, is it small piece folders? We call them small piece folders, which basically it's what it is. It's a small piece that folds things, right? Most of this is automated nowadays. There's not a lot of human hands touching it, but the way the plants are designed, high output, right? That's a hospital, right? The acute side, high output. We got to get stuff through sheets, blankets, pillowcases. That's what you're really processing a lot of. And one standard or two standard gowns. Outpatient, you've got, 30 different products, and how that's being processed is different. How it's being loaded is different. All that formulas are different. So how the main big difference is how the plant is designed.
So it's plant logistics. That's the differentiation that creates the issue. Is they would have to literally have two different plants. So when maybe a company decides to go to market, or because they're already in the market, they're thinking to themselves, not only do we have to get a new fleet of vehicles to open up into this other space, but we literally have to build a different plant, or we need to double or who knows, maybe the non-acute setting, because it's small piece, you have to, triple the size of the plant to be able to accommodate that. It's really, they're building a brand new infrastructure. They're not leveraging existing infrastructure to bring savings to allow them to expand the services. Is that a good summation?
That is a good summation. Exactly right. It's hard to take a hospital and throw it through a non-acute design plant. The cost per piece processing, the profit margin.
Yeah, they couldn't compete.
So it's drastically reduced. We couldn't compete at all. So, and frankly, what you just said, that model exists currently. There are folks in, the Northeast, that are doing that, and they have plants not too far from each other, actually. One's doing the acute and one's doing the non-acute, and being serviced totally different.
And Justin, you rolled over it and you said fleet. I think that's so important. The amount of volume with the trucks, with the fleet services, with these giant vans that have the company on the side, that's a giant piece of the puzzle too. And think about all the employees, the fleet. That's pretty big, isn't it, Jason?
It's huge. So, obviously, your overhead there is a lot different than it is when you're just driving semis. Now, those semis might be 2 or 3 semis a day going back and forth, but still, the cost to deliver those services is a lot different than it is with a fleet of 150 trucks running around, making a whole bunch of stops.
Even human resources, just managing the workforce is a completely different. Like even on the larger trucks, you might not even have to own the fleet. You might be able to leverage existing, partners to build that out versus all those different vans and the people that are driving them and having more, not just a loading dock landing, but an actual relationship with the non-acute setting that they're reaching. It's a completely different personnel model too.
The people and the people. So you're hitting on something else here too. Is the person actually servicing the account is totally different, right? It's a totally different hiring profile. A semi-truck driver who's, for an expert in what they do are pushing carts off and pushing carts on. We call that cart exchange. A different model where you have a service rep. They're actually going in, they're looking at inventory levels, they're stocking shelves, they're doing
there's par management
there.
Where you don't,
par level management. I mean, we used to count everything on site. We obviously stopped that a long time ago, but things used to get counted on site. Now we've brought a lot of that in-house. I mean, that's one thing that I think, if you're not asking your linen provider now, most, I would say, 80% of them have the technology in their facilities where they know a lot. Like, we know what you're using. Like, we know what you're using. Now, there's a part of this, there's no secret sauce here, but there is a part of that where there's an assumption there's stuff there that you're not using. And that's built into the model when you look at costs and how they profit on that piece of it. But understanding utilization, you don't really have to count it anymore. You just got to ask for the reporting. I mean, the data's there. You just got to get a good partner that's going to be transparent about the data, right? And then be transparent about what it's going to cost us to kind of get to the right place.
So you said something before where you were sort of approximating 500,000 in spend for linen services per hospital. And then you started to kind of extrapolate that, a large health system, 23 hospitals. Here's that number. That starts to make it more intriguing for strategic sourcing to try to bite off some savings and then looking at the market nationally. But seriously, how do you predict a budget, or how does, step one, how do you even know, you're saying 500,000, but that's not the same for a 500 bed hospital versus $150 hospital. Right.
That's on average.
On average.
Yeah.
So now you're trying to nail down this budget a little bit, and they can't, if they've got anywhere from 20 to 30 different contracts in place, depending on setting, trying to predict that budget, acute versus non-acute, multiple different contracts. They might not even know how much they're spending today. How do they even know what to budget? And I'm sure there are little in wars of one company trying to pilfer the business off the other company. So well, wait, we're spending more with you now. Well, you should be, because we won all this business over here. Well, wait a second. How do I actually corroborate that to know that it's not just a price increase, or, we're duplicating, or we're not even in contract compliance? Just talk to me about budgeting. Is that even possible?
And Jason, before you take this on, because I know you're going to dive into it, but you got to think about the bed size. You got to think about your census, time of year, all these.
That's where I was just going. Yeah.
Go, run and go.
Census, your inpatient days. I mean, in reality, Justin, what you're hitting on is exactly why the majority of them just give up. They're just like, we can't do it. Maybe we'll get down to 5 or 6 and we'll call it a day, and I'll get 30 grand out of this. I'm moving on to other things, because they don't really, again, they're trying to manage a process from a different place, not actually see it operationally and how things are kind of being moved and moved around. So I think it's exactly what you're describing is why it never happens. And then budgeting becomes almost unpredictable as well. So they just give up. They move on to something else. It's like low hanging fruit. It's not low hanging for them. And it's just part of the deal. Our supply chain professionals are stressed. There's not, there's less and less of them. They're doing more with less. And there's almost only so much time to be spent on this thing. So I think that's where, we talk about partnering with the right SMEs, as we are calling it, partnering with the right people that kind of know where to go look and the questions to ask, what's really available out there from the supplier perspective. They don't even really understand what to ask, what questions to ask. I've been through more RFPs in 20 years, and it's always mind boggling. And I'm talking through with the largest health systems in the country, the largest GPOs in the country that have purchase services division that I've worked with. And they all tell me the same thing. We don't understand it. Because we don't know really what to ask and where to go look. You can, Justin, budget for it if you can whittle this thing down, right? And then start
it's just not at a manageable size. And so you could end up doing a lot of work without being able to measure the results. And to the other side of the coin on, really getting a handle on it is, and especially with all these different contracts, it's the quality side. What are the service level agreements, and how much variation is there from your perspective?
That it's a huge variation. And I think quality was always a struggle in our world, for developing KPIs in general. It was a struggle because everybody just kind of wants to go to utilization right away. That's easy. Let's pick utilization. Let's look at fill rate. Let's look at inpatient day census. Let's figure out how we're doing that. Some things that we were kind of on the edge of doing and trying to kind of get out there was looking at, products per procedure, looking at what that kind of looked like and what your utilization looked like there as well. But quality was always it was out there, but it's how do you measure that? Because everybody's idea of what quality is.
It's a purchase service, so though. Really, that's always the issue. And if you're a national player, you can't say that the quality in one market is the same as another. That's the nature of the purchase services struggle. And, you mentioned the drivers are more like account managers. Hey, guess what? Service level agreements for a truck showing up and doing container exchange is very different than you're helping us manage our par levels, and are you doing it competently, and what kind of training does your staff go through? So even those service level agreements, they're going to be widely different in the acute versus non-acute as well. Is that another reason why you don't see companies dabbling in both? Even the way they would do a business review would not be at all a similar conversation.
It's not the same. It's not similar at all. And they're asking for different things. And I think that if you can, and I think from the supply chain perspective, as they're trying to manage these contracts, or from the health system perspective, if you could find those partners that are doing a great job they have like their own internal systems of measuring quality within the service. There is ways of doing it, right? Net Promoter is a great way of doing it, right? So measuring the quality within the service, measuring the quality of the product as well. And one way of helping with quality of product is to standardize the product. Like a lot of companies want to have we'll give you everything, whatever you want, Johnny, we'll give it to you. Instead of saying, well, listen, these are our 14 gowns and that's it. And these are this is the modalities they service. And we keep it to these 14 because we can help manage quality that way. They're scalable across the country. We can source them and we can manage quality. So I think, it's about, again, it goes back to asking the right questions of the vendor that you're working with, your linen provider, to find out what they're doing on their end to kind of manage those systems, and seeing how you can then bring it to bear and develop KPIs jointly. And by the way, that's the way to do this, is to jointly come up with KPIs.
You said KPIs, so here we go. So, Jason, exactly. Ebb and flow. I've seen them. I've seen them in local agreements. I've seen them as appendices added to an enhanced GPO agreement. I've seen them. And just diving into those KPIs, how do you best... Are they a moving target to that point, Jason? Do we try to set them up? Do we try to evolve? Do we try to make them generic? Do we do QBRs based on the spend? What's your thoughts on best practices on building some true KPIs into the contracting agreement?
First, keep them simple. Don't overcomplicate them. And when I say keep them simple, keep them one that we can all measure it. One, come to agreement. But when I say keep them simple, keep them to a couple. I've seen some. And by the way, taking ourselves in linen, outside of linen, and I'm sure that's the experience that you've seen as well. It's like you go to a QBR and it's like 100 pages, and everybody fell asleep by the end. And what we were trying to do is implement. It should be like 2-3 pages. That's it. That's all this thing should be. What can we agree? And I do think they should be updated and changed. What are we trying to achieve in the short term and long term? And if you're measuring the same thing for 3 years, I don't know what you're changing really. What are you changing at that point? And there's only so much, and spend. Listen, you're only going to get so much out of the product, right? You only can squeeze so much blood from the rock. So, really what they should be looking at is efficiencies, looking at, continuous improvement opportunities. Those are definitely some good, thought process around KPIs, but keep them simple. Keep them simple, keep them few, do QBRs, or I used to call them periodic reviews, because I said Q and then everybody said we had to do them 4 times a year. And I'm like, well, if the customer doesn't really want to do it 4 times a year, why are we forcing them? So just a periodic business review. Maybe it's twice a year and we're checking in other times.
That's a great line. Periodic business reviews, which totally makes sense. QBRs are like check the box. Periodic business reviews seem to have more qualitative, quantitative effort. I like it. Yeah. Like it a lot, Jason.
One good idea for the day.
Well, so I have a question that I think is going to lead to another good idea for the day, which is you're talking about 20 to 30 contracts in some cases, whittling it down to, 2 to 4, something manageable. The problem is I'm certain that all these agreements are terminating over staggered periods of time, trying to pull it together. And I think an obvious takeaway for me is if I were to tackle this category, if I were to do any RFPs or any sourcing initiatives, you would probably recommend focus on non-acute, and have somebody else focus on acute. Segment those, do them separately, at least until you're down to 2 to 3, and then start to evaluate opportunity from there. But if you're in a 20 to 30 contract scenario, it seems best to define those contracts as non-acute or acute, start with one and begin to start working on your consolidation and your KPIs. But so then what do? Do you RFP every time one of those comes up and slowly whittle it down? How do they begin to consolidate this so that because I feel like first phase is just getting it to a place where it could be managed. You're not even concerned about fully managing it. Get it to a place where it's manageable and focus on quality and cost control through that process. Correct?
Absolutely. Yeah. And I think you go back to we talked about a little bit ago about the groups, right? Buying groups or stakeholders, partnering with your finance team. You could capture this pretty quickly if you understand how things are getting billed back to which cost center and what those line items are called. So you can actually, and I've seen systems do it pretty well if they know where to go, they can extrapolate pretty quickly. Like, who are all our vendors out there in the world? Like, who are we paying? Like, we're paying, like, guys, it's coming from somewhere. So who are we paying? Maybe there's some ancillary cash, petty cash stuff happening out there. Whatever, we'll deal with that. We probably no contract anyways. Let's look at, and then just, I mean, this is obvious, but prioritize from, what is our highest spend? What does that look like? What's the best bang for the buck? But you're right. Looking at it, non-acute and acute is your acute stuff. You're going to know who your vendor is. I mean, it's the volume, right? Is sitting in the acute side. It's the non-acute that they tend to try to have to figure out. Like, they don't really know how many people are out there doing this, but then start whittling it down. Now, I've seen RFPs. I've been through a lot of them. And I think that what always again happens is that they don't really, I don't think folks go into it understanding that all of these contracts are all over the place. So really understanding and quickly putting a matrix together, which is not that hard to do either. If you kind of just sit down and do a little bit of that work of what's going to even cost me to make a change? What's the cost of change here? I've got 30 vendors. These are all their the termination dates for their agreements. This is what my spend is. This is the cost to change, right? And we're talking about penalties, right? What is that? And we'll work that penalty out on the back end later. And then how do I partner with some key ones potentially to kind of bring to bear, maybe not even having to do an RFP potentially.
How do you whittle it down then? Like, are there maybe some minimum qualifications? Because I can imagine with some of these contracts with a lower dollar spend, they're just totally under the radar in terms of basic supplier requirements. And then as with any agreement, as the supplier grows in size and volume, they get on the radar for more triggers around those minimum requirements. But is there a key minimum set that's been established by industry regulations or guidelines, or is it simply best practices? What would be if they got to have this and this and this to continue to be at the table?
Yeah. Yeah. And I think the fastest way, and that's a great point, Justin, you want to eliminate some of the players right away, just to kind of consolidate that list is, Joint Commission has a play in here too, right? And it's changed over the years. Now it's a little looser than it used to be, but it's still there, and they have to be processed to a standard, right? So we say to a standard. There's two organizations out there right now, the two top ones, Healthcare Laundry Accreditation Council, so HLAC, right? And TRSA, which is the trade organization for textiles and rental uniforms. They have hygienically clean. So there's two standards, and processing facilities are accredited by those, either both, which most are doing both now. Healthcare Laundry Accreditation Council, by the way, is more process driven. Hygienically clean is more testing driven, right? So they're more about testing things, swiping carts, looking at bacteria, all that kind of stuff.
Real quick, would you say the testing one is more of an infection prevention focus, and the other one is more delivery model focused?
It is more about how it's being processed in the facility. Now, I say that, and I do know that they are trying. HLAC is trying to kind of move towards some of that testing. They've trying to change their language a little bit in their accreditation process. At the same time, when you're going back to eliminating people right away, are you accredited to be processing medical textiles? Yes or no? And if the answer is, well, no, and I've seen it where it's it's a fold and wash here. Okay. That's out. We can't do it. Sorry, guys. That's part of the deal is you have to be accredited in some fashion to be able to do that. So that helps you right away eliminate some of the players and kind of whittle that list down. Being prepared though, to move some of that, you got to be prepared too, because you're giving notice to have a plan. How am I going to execute when I start moving that volume somewhere?
Yeah. Whoever you're going to go with needs to be ready for that volume. Let's talk about that a little bit too, in terms of the best practices. This might sometimes be something less transparent, right? You get a sales rep. They want to grow their book of business and maybe they overcommit. Yeah, we could do that. We could do that. We could do that. And then the reality is that it is such a substantial impact on the local plant that maybe they can't do that all at once. Is that a common issue that happens when hospitals do conversions? And, what questions should they be asking of their supplier that they're going to lean on to take on the increased volumes?
I'll say the number one suggestion I would have is go visit the plant. Go visit the processing facility. I want a tour. I want to go look. Take me on a tour. Because I can tell you whatever I want to tell you. I can tell you how many pounds I can process, what my capacity is, where am I at. Questions I would ask is, what's your capacity? What are you currently processing? How many pounds can you process? What's your expansion planning? If, for instance, the pounds I'm bringing to the table is going to put you over, what does that look like? But I would say I would be asking those questions, but I would be visiting the facility. And if you're doing RFPs and you're narrowing it down to, 3 or 4, whatever that number is, the time spent isn't that great. I mean, I do think again, going back to stakeholders here, when you look at that as buyer, going right back to what we were talking about earlier, is your supply chain professional going to be the one that always able to do that? Well, maybe not. Maybe infection control, which they should be. And materials are the ones going doing those plant tours, right? They're the ones going out there in that RFP process to take a look at the facility, make sure they're meeting the standard, but also they can handle the volume.
Jason, you brought up another really good point. We talked about RFPs, how we're going to award it. What's the service going to look like? Explain to our listeners on the podcast, explain to them, are we billed per pound? Are we billed for the item? The size scope? That is a giant, giant piece on how that comes in and comes back out. Can you walk through that a little bit, please?
Absolutely. It's two different models that are out there, per pound and per piece. Those are the two prevalent models. Per pound usually lives in the acute side, right? Because again, I'm talking high volume, a set amount of products that are not that vast. And then your per piece, because then this all rolls back to, by the way, on how we operate in the sense of the vendor side, the supplier side, and how we can keep functioning as a company, right? Like, how are we going to make money at this thing? When you're looking at the non-acute side, that cost per piece is usually how it operates. Now, I have seen it. I've seen it happen where we have some companies trying to take that cost per piece model. And I've actually implemented this once at a small hospital. I did it. That cost per piece model and stick it into an acute setting with those service levels that go along with it, right? So you're paying for that. It wasn't sustainable for the health system itself because it just became too costly, right? So they went back to the other way they were doing it with putting some some KPIs in place to make sure they can control the quality piece of it. But I am seeing it resurge again within a national provider now where they're trying to, again, take that per piece model and put it into hospitals itself. And we'll see how that shakes out. I don't know. That's just starting to happen. I think over the last 8-9 months where I've been hearing the rumblings that it's starting to go out there.
No, I appreciate it. It's just like, how do you pay for it? I mean, it's per pound. I mean, volumes and volumes and volumes coming in. Can you imagine trying to count per item? That ain't going to happen. You're exhausted. The labor pool on that is like hire a full-time person to count dirty laundry. Not happening.
Well, then you wonder how they're measuring it too. Back in the day, are they weighing it on site? Are we weighing it at our facility and then letting them weigh it? Or are we sending it out and just trusting the fact that the weight comes back in? Is it clean weight? Is it dirty weight? That matters, by the way, because dirty weight, obviously with fluids and things, it weighs more. Now we should be able to extrapolate in some fashion. There's some formulas to kind of pull that out, percentages that they'll build in, but there's a lot there, right? There's a lot of checks and balances. Most hospitals have on their back dock, there's a scale, right? The cart goes in. They put it on, they scale, somebody's writing it, and it's getting pulled out. And some companies are using RFID now as well. So that is out there. I'll tell you, there's not a great return on the supplier side, vendor side for that. But there are companies that are implementing that where pull it into the truck and it just, bloop, and it tags it all and it grabs everything that's in there, right? So you can tell all the pieces that are in that cart as it kind of like rolls out the building.
Man, what an interesting sales strategy. We'll charge you X, right? And you're, per pound. But you're not apples to apples on your bid, and nobody realizes that you were talking about dirty versus laundered linen. That's really interesting. Okay, we're going to stop there. We're at the end of time, but this was phenomenal. Jason, great deep dive. Is there anything that you think we're missing, or maybe something that you mentioned RFID, but maybe more forward thinking, or what's around the corner, future oriented, that you might want to mention before we wrap it all up?
I think when you look at future state is the technology, looking at your vendor partners really and asking also what technology they're bringing into their facility. What's their plan? What's their expansion planning? What's their business plan look like? These are usually long-term agreements. 3 to 5 years. You don't see anybody doing linen agreements for a year. If they tell you that, it's usually not happening. There's no return on that for the vendor side. So asking what their plan is around, are they bringing the most up-to-date technology into their facilities? Again, and then passing that savings on. So the only way sometimes to really get savings out of some of these places is to approve efficiencies. Is the company approving efficiencies? So making sure to ask the questions, I think, are really important, and making sure those questions are involving kind of future state as well as you partner together, I think are imperative.
Jason, great job. Thanks so much for coming on.
Awesome. Thanks, guys. It's been fun.
That was Jason Isherwood, VP of Enterprise Sales at ShiftMed, talking about linen services and the complexity of not only contracting and establishing KPIs, but consolidation. And right there at the end, Gary, I thought he gave some really great tips, because he did say in a lot of cases, supply chain starts to look at this, they become overwhelmed, and they kind of give up. And so I think having some good ideas for where to get started, maybe to chip away at it, and then as you get a little bit more consolidated, you can get more sophisticated in identifying the savings opportunity that exists.
Yeah, Justin, I really liked his quality discussion and his point of visit the facility if you can. Go take a look at their operations, see what it looks like. We're supporting Joint Commission. It's a big part of that. And I think just some best practices as we try to streamline some of that contractual pieces. And if it does go out for RFP, these are some really key components that I think we need to look at. But just, he is a SME in his area. Lots of great information as a subject matter expert. And I think he really tied in who to talk to at the acute and non-acute facility. So great job.
All right. On behalf of Gary and myself, everyone, thank you for listening to this episode of Power Supply.
Thank you for listening to this week's episode of Power Supply. As a reminder, you can help support us by subscribing on your favorite podcast app or by downloading the smartphone app on your iPhone or Android. Simply search for Power Supply in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@powersupplymedia.net. We look forward to hearing from you.